today about pathologies of late pregnancy. Yesterday we worked on the early part of a pregnancy. So today we're talking about the later parts of the pregnancy and what you might see pathologically. So today we're going to kind of talk about some major complications, but not all of them. We only have an hour, so we're going to kind of hit the big ones. And then we're going to look at some risk factors, diagnostic criteria, and some management for these late pathologies of late pregnancy. And then we're going to try to differentiate between hypertensive disorders of pregnancy, gestational diabetes, fetal growth anomalies, preterm, postdates, and post-term deliveries. And then just talk about a few real life cases and some of the treatment. Okay, so take down your pads and papers or your computers and kind of do a little bit of a pre-assessment for yourself. Thinking about what are the main hypertensive disorders of pregnancy. And again, like most lectures this week, we'll revisit these and think about, oh, okay, can we name these a little bit more at the end? How is gestational diabetes diagnosed? If you remember way back 4 days ago on Monday, we talked about gestational diabetes a little bit, and we talked about how in the second trimester, that's when you're going to see the most insulin resistance in a pregnancy. So that's often when we start to diagnose. What is intrahepatic cholestasis of pregnancy, or ICP? Okay. And what defines intrauterine growth restriction, IUGR? So that's of the fetus. What defines that? And what are the gestational age ranges for preterm, postdates, and post-term pregnancies? Okay, we're going to jump right into it. Hypertensive disorders of pregnancy. So there's a few different types, so we're going to talk about all of them. One of them is chronic hypertension. So that's if somebody comes into your initial visit, they already have hypertension, right? They're either at, either diagnostic criteria 140 over 90 or less than that, 130 over 90, something like that. But it presents before 20 weeks gestation. Or it persists postpartum. So that's called chronic hypertension. Gestational hypertension is new onset of hypertension after 20 weeks of gestation. And you have no signs of proteinuria. So you're not spilling any protein in your urine. That's called gestational hypertension. White coat hypertension, we already talked a little bit about that, and I think you've heard about that before. That's when you have a BP, blood pressure that's elevated in the clinic, but normal at home if they have a way of testing it at home. Preeclampsia, so that's, of course, also previously known as toxemia or pregnancy-induced hypertension. It's now just called preeclampsia, but you may see some of those older terms in literature. But preeclampsia is new hypertension plus proteinuria or end organ dysfunction after 20 weeks. So that's, we're going to talk a little bit more about, so preeclampsia really is the main disease of pregnancy related to high blood pressure. I think remembering what we've spoken to about this week about preeclampsia is possibly related to how the spiral arteries are implanted into the myometrium when a baby develops way back in the start of a pregnancy. We don't know why it happens for people. We know there are some risk factors. So certain ethnic groups have a risk factor for preeclampsia. Lower age of pregnancy, maternal age is a risk factor. Previously, having preeclampsia is a risk factor. Having chronic or gestational hypertension is also a risk factor for preeclampsia. And preeclampsia, of course, it's called preeclampsia. Preeclampsia meaning seizure is we're at the stage where you are trying to not prevent a seizure. So how does that happen? So the first thing is correct diagnosis. And so when you are having somebody with high blood pressure and you need further follow-up, so that's lab testing. So you will be testing that urine. Back in the old day, we used to do a 24-hour urine sample to get a protein. literally women would walk around with a jug of urine and take that. That's the gold standard of getting protein in urine. We don't do that anymore. What we do now is something called urine protein creatinine ratio. The issue with that is it takes some time to process, so you're not going to get an immediate value on that. But you can do a preliminary urine dipstick and see how much protein what somebody is spilling, anywhere from +2 or more. So that can tell you that you have protein. You're also taking some lab values, right? So mostly liver function studies, right? So your AST or ALT, but also you are looking at your complete blood count, right? And the main thing that you're looking at is platelets. So if you have lower platelets in your complete blood, thank you, Sophia, in your complete blood count, that's also a sign that lower platelets that you have preeclampsia brewing. Um, there's also lots of different values of bloods that you might help to diagnose, but the main ones are liver function studies and your CBC and your proteinuria. So that's how it's diagnosed. You often see people when you're diagnosing is you need to get an ultrasound on the baby, and you're going to look at the biophysical profile of a fetus, because often with preeclampsia you're going to get intrauterine growth restriction. So those go hand in glove. So you also want to see what's the baby kind of growing like, what are the measurements like. In some high income places in the first trimester, you do things like genetic screening. So first trimester screen and a couple of values at that time can also indicate that a person is at risk for preeclampsia. So if you have a low PAP-A and a high beta HCG on your first trimester screen, you're going to be at risk for preeclampsia. So, and eclampsia, probably not everybody in their long career in obstetrics has seen a eclamptic seizure. I have seen one, and um, and that was way back in 1997, maybe. And it was my first week off of labor and delivery nursing training, and it was one of my first patients, and she had a eclamptic fit. And actually, the treatment for preeclampsia is magnesium sulfate, so a 4-gram loading dose and a gram an hour afterwards. So if you have somebody that's preeclamptic, and depending on their gestational age, really the treatment for preeclampsia is delivery of the placenta. So if you have severe preeclampsia before somebody's term gestation, you have to think about the cost benefit ratio of delivering that baby preterm or keeping it in, managing the uh, the uh, the the preeclampsia itself. So it kind of depends on a lot of things what happens in terms of like gestational age, um, you know, um, severity of the preeclampsia, and when you are treating so magnesium sulfate doesn't actually treat the blood pressure. Okay, it just helps minimize that risk of seizure. If a person, and sort of our diagnostic criteria for treating blood pressure, we really don't want to cause a stroke. So if we have blood pressures around 160 over 110, we actually are treating with, mostly where I work, we use labetalol. And, and the reason why you'll see some places use hydralazine, but the reason why we don't use hydralazine that often is because it tends to bottom that blood pressure very quickly, which then in turn can um, make that fetus's heart rate abnormal. So you'll see a lot more labetalol, especially when somebody's at a risk um, for stroke. Now, if you have gestational hypertension and you don't have preeclampsia with it, you'll often see people started on labetalol in the oral form in their clinic. So there's lots of different things about preeclampsia. It's the other story I have with preeclampsia is when I was a midwife in Portland, Oregon. We worked in a high risk setting, and I had a person that was, just a normally physiologic 20-year-old um, that was pregnant with her first baby. I'd seen her a couple of times in clinic. We had a big practice, about 8 midwives, so you don't often see the same person, that often. But I'd seen her a couple of times, and I happened to be early to clinic one day, which is not normal for me. I'm always late. Anyway, I went to clinic. I was not on call, and so I was back there getting ready for the day of the clinic, and I got a call from the front office, and she said, our admin said, there's this patient on the phone that wants to talk to you. And I said, okay. So I got on the phone, I talked to her, and I said, and she was very shaky. Her voice was very, um, you know, just nervous. And she said, Deepa, I don't feel very good. Something's wrong. And I just said, hang up, dial 911, and get to the hospital. So when you're pregnant, people say things like that to you, you kind of take it seriously, right? And so anyway, I called the midwife on call who met her as she was coming into the ER. She had a seizure in the ER. She was fine, baby was fine, but that's a non-normal presentation of preeclampsia. When it happens, it can happen pretty fast. Um, but even actually a seizure doesn't actually precipitate a cesarean section too. If you can get it under control, mostly people will probably, start to have a bit of a anxiety when somebody seizes in front of you, and think about that. But really, when people are preeclamptic, it's think about what the management of the labor might be depending on gestational age. So if they're prima gravida, which their prima gravidas are at risk for preeclampsia, right? You have to think about cervical ripening, right? So it's not automatically your preeclampsia, you have a C-section. You start to cervical ripening, you start to get that, labor induced, and go from there. So that's, yeah, preeclampsia is something that you will be dealing with or treating in your career if you end up with obstetrics. So uh, gestational diabetes, moving on. So another thing that you will not be in obstetrics very long without seeing gestational diabetes. Um, it's we talked about the screening is really at 24 to 28 weeks. We start where I work with the 50-gram glucose challenge tests, or glucose tolerance test. It's called either GTT or GCT, and what that means is that they don't have to fast at 28 weeks, but you tell them don't eat a big pasta meal at 12 o'clock at night and then go in the morning and take this test, because you're going to have an elevated value, and then you're going to have to do it again to do the actual diagnostic test. So you just tell them to eat like you normally would, and then in the morning they schedule the thing, they drink the sugary drink, and then they take their bloods an hour after that and see how they're processing the sugar. If they don't pass that, then they end up taking the oral glucose tolerance test, and that's with more grams of oral glucose, and then that is fasting. So they fast 8 hours before that, and then they take their fasting blood sugar in an hour and at 2 hours. So it's a longer test. Cool. It's like karaoke. Okay. You don't want me to sing, I promise. Okay. So first line is diet and exercise. If we can get these folks to, oh, I was going to say, I forgot to say about preeclampsia, is that when you have preeclampsia, guess what you're at risk for when you get older? Hypertension. Yeah. Yeah, that's a great question. Yeah, you dose, it's the same dosage. And you do sometimes what you have to worry about with magnesium sulfate is magnesium toxicity. So these folks are not, they don't stay at our hospital in a rural level one. They go to a center where you have very, very, you have pumps that are doing your magnesium, and also they have fluid overload, right? There's a lot of third spacing with preeclampsia, so you have to watch their fluid very carefully, their intakes and output. You have to watch them for magnesium toxicity. So these folks are getting blood pressures like every 15 minutes. They're getting their vital signs every hour, because preeclampsia is a multi-system disorder. Depending on what presents, you have to like treat for that. So we often say that, okay, this is fine too. This is actually, is this okay? Okay. So basically, we have to make sure we keep the room really quiet because of the neuro involvement of that. So it can cause a seizure, right? So we keep the room. It's not the place for like 25 people to come in the room and be in the delivery, and it's a party. It's not like that at all. So it's a very quiet. She's a very sick person, and so we're monitoring those mag levels. We used to take mag levels, in when somebody's admitted for preeclampsia. I think now we just manage symptomatically. And if you do have magnesium toxicity, you're starting with your CABs, right? So you start to manage her airway and her breathing, her circulation, and then you actually turn off the magnesium sulfate if she's toxic. And then the antidote for that is calcium gluconate, to reverse that mag. Again, at that point, it's a really complicated, complex thing where you have to have that baby delivered. She might be a prima gravida at like 2 centimeters. She's got magnesium toxicity. It might make sense at that point to do a C-section and get that placenta out so she can start to get better. A person will stay on magnesium sulfate for a good 24 hours after a delivery. And then like one of the higher risks, so mostly, I think it's like 25% of preeclamptic people will have a seizure. Well, those that have seizures, 25% of the time it will be antenatally, 50% of the time it'll be intrapartum, and another 25% postpartum. The highest risk postpartum is day 3 to 6. So, you have to really counsel your patients, and you have to have very short cord of how you work with them. In the global sphere, where you work in low and middle income countries, where you don't have the IV pumps and you don't have the way to titrate the magnesium, you actually give the Pritchard method, where you give it huge, 10 cc's of magnesium in each, in your buttocks. Like, it's very, very painful. So you can add a little bit of lignocaine in that syringe. But that's what lots of people do in different parts of the world where I've taught about preeclampsia, is that's where you do. And sometimes in rural Canada, to get the person to the center, it's a lot harder to get somebody from a low resource place to a higher urban center. Like, you wouldn't have pumps and things like that. So you do use the IM injection of magnesium sulfate. But yeah. Some places use methyl dopa still, some places in the global sphere, but in higher income countries, you're going to see magnesium mostly being used for that. But methyl dopa sometimes is used instead of labetalol and hydralazine to treat, especially in low resource settings. Yeah, good questions. Yeah. Okay. But just like preeclampsia, diabetes, guess what you're at risk for if you have gestational diabetes later in life? Diabetes, right? So you're really counseling these folks on, like, this is happening in your pregnancy. You're going to be higher risk later on. So you got to work with us here. We don't want to see you in another 20 years and have to be treating you for hypertension or diabetes. But diet, exercise, that's the main thing. We're all, we still forget about that. Right now we have this whole, these new medications for weight loss, right? But if we still come back to that as the primary way to manage health, as humans were kind of designed to be, eating certain foods and exercising daily, we need to really think about that. Now, depending on what your pregnant person comes to you, whether or not they're regular exercisers or not, there's nothing wrong with starting a daily habit of walking in a pregnancy, stretching in a pregnancy, low impact exercise. Exercise, of course, is a hypoglycemic, right? So it's going to help manage, especially at the times when there's higher insulin resistance in the pregnancy. Second line treatment is insulin. So insulin a treatment, it really risks out um, these folks from midwifery care or family practice care for low risk. So if they're typically on insulin, they're usually going to be transferred to an OB for care, at least where I work. So that's if a person's sugars, are upwards of like, you can't get them below 5, they're really around the 8, 9, 10 range, then they do need a second line of treatment, and so that's with insulin. Okay, moving right along to ICP, intrahepatic cholestasis of pregnancy. So you're going to get that pruritus, so especially in the palms and the soles of your feet. So you also might get a little bit of dark urine and a little bit of jaundice appearing skin and sclera. So the diagnostic criteria is elevated bile salts, right? Again, sometimes that takes a little bit longer to come back and in terms of your labs. So you might be just treating based on clinical symptoms. So UDCA is kind of the treatment for ICP. And then you are going to do an early delivery around 36 or 37 weeks because ICP has a high incidence of stillbirth related to it. So when you have your pregnant folks and they're presenting around 35, 34 weeks with itchiness, you got to kind of take it seriously because of the risk for stillbirth. IUGR, we've talked about this a few times, so we know that things are risk factors for IUGR. So malnutrition, but also preeclampsia, even all the hypertensions are related to IUGR. So it's basically how we look at growth, right? When your babies come to your clinic, if they're less than 10 percentile in growth, they're small. And similarly for a fetus, if they're less than 10 percentile when they're being measured, they're considered to be small for gestational age and IUGR. It's really related to that placental function. So like preeclampsia, the placental function is an organ. So that's going to be like preeclampsia is multi-system, right? So that placenta is an organ. It's going to affect that placenta. And you're going to have maternal hypertension is another cause. Like I said, all of them. Infections can sometimes cause IUGR and some genetics disorders. And then what the treatment is serial ultrasound. So we talked about those Doppler studies. You still want to see that really, that waveform in the like things are not restricted. There's no restricted flow. You want to see that low pressure placenta. And it's interesting. Like if you ever get into neonatal stuff, when a baby is in utero, the placenta becomes it's a very low pressure system. So that blood can flow very easily. Immediately after the baby's born and they take their first breath, right? What do? We wait a minute or more for natural cord clamping. We know that's super good for the babies. And it helps prevent anemia even up to 6 months of life. But what happens afterwards? So, you cut and clamp the cord. Also, Mother Nature does it itself, right? If you ever feel an umbilical cord after a baby's born, it's very, very cold and it constricts. Mother Nature constricts that cord anyway. So that constriction does what to the placenta when a baby's born? It makes that placenta high pressure, right? There's no more there. So then naturally and then in utero, the fetal lungs are high pressure because you're not having air going through that, right? It's bypassing the lungs. But as soon as that baby's born, the first air is taken and the cord is clamped around that time, the lungs become a low pressure system. So now the baby starts breathing and the fluid is moving out of the alveoli. So that's kind of I mean, it's pretty amazing. All that to say is that Doppler studies really should have that really low resistance that you're seeing, and so in IUGR you're going to see often restricted or even reversed flow in a uterine artery. So um, close monitoring is imperative, and early delivery if you're getting abnormal fetal heart rates. Um, okay, PUPPs. So this is pruritic urticarial papules and plaques of pregnancy. Again, another itchy type thing, and it's also has some itchy red plaques starting on abdomen and spreading. Now, the difference between ICP and PUPPs is ICP doesn't typically have a rash associated with it. It's just this generalized feeling, although it may become a rash if somebody's itching it. PUPPs, on the other hand, has a rash. Um, and they spread, and it's typically on the abdomen, right? Um, and risk factors: first pregnancy, multiple gestations, and your management is topical steroids, antihistamines for symptom relief. And really, the thing is differentiating different, these are only two of many different types of things that can happen in terms of dermatologically in a pregnant person, but some of the main ones that you might see, so ICP and PUPPs, just differentiating it. They both have some risk for it, but obviously ICP has more risk for a stillbirth. That's why that delivery is required. Usually PUPPs kind of resolves postpartum and they're not no fetal risk, but it can be like really, really uncomfortable for the pregnant person. So management with topical creams is super important. This talk is making me itchy. Uh, okay, GBS. Thought I'd mention this again. GBS has no consequence for the pregnant person. 30% of people walking around us have GBS, right? And it usually it's just a bacteria, different than the eye gas, GAS, right? That's different. That's the bacteria that causes strep throat. That's the one that that's why we wear masks when we deliver babies, because we can be carrier of GAS, which can be fatal for the pregnant person. So anytime you're within 2 meters of the perineum, you need to be masking and wearing glasses, because you could be a carrier for group A strep, and it can be quite fatal. If you all you have to do is look up eye gas, pregnant person passed away, and you'll see recent reports of that. So really masking, is important. And so, when I talk to our midwifery students who deliver everywhere, home, hospital, birth center, we really have to impress upon them and their preceptors that you have to wear masks at home. Now, people don't love somebody come in with their nuclear suit on at a home delivery. It doesn't quite uh, match the vibe, but it's really important to prevent eye gas. Most of the time, when a pregnant person gets eye gas, it's not. I think it's about 15 to 30% related to healthcare provider. It's usually somebody coming in that has it. So that's the reason why, to keep people that are sick not only away from the baby but the mom as well. So that's why eye gassing. But group beta strep is just a normal thing that we have, and it doesn't make any difference if we have it or not until you're pregnant, right? So now that what we're worried about with that is early onset GBS disease of the newborn. So mostly that it happens when the baby goes through the birth canal, right? And they get exposed to the GBS. So really the only treatment for that is intrapartum and antibiotic prophylaxis, IAP. So that's IV medication with antibiotics. But and the fatality of that, it's low. It's not a huge amount of fatality, but IAP does prevent early onset GBS disease in the newborn pretty well. So we have those studies. Universal screening. Yeah, go ahead. Yeah. Yeah, I mean, there's a lot of, I don't think there's any real evidence on things like, things people use yogurt or garlic or things like that. I mean, if it makes somebody feel better and they feel like they're doing on it. Now we do have this issue of vaccine and antibiotic um, deniers and things like that. And again, it's people's choice of what they want to do. And some people will come to you and say, I don't want any antibiotics. I don't want that. I don't want that exposure. And then so you have to walk them through the statistics, right? So we know that with intrapartum antibiotic prophylaxis, we are really reducing that risk of that kid having early onset GBS disease. And what does that look like? Pneumonia, meningitis. You can get these really sick kids and end up septic, and I think like, it's a small percentage of that that's fatal, but there's a lot of other ways that that baby can get sick and have long-term sequelae. So you have to talk about what's the evidence, right? The evidence is that intrapartum antibiotics is a pretty good prophylaxis is pretty good at preventing that. Um, Now, I said mostly a baby is exposed to GBS as they're going through the canal, but sometimes it actually can go through the amniotic membranes in utero. But what does the IAP do? It decreases the colony counts for the mom, right? It also a little a bit of the antibiotic gets to the fetus to help prevent any infection as it's being born through the canal. So yeah, there's lots of people try different things, and and you can't just, unfortunately, you can't just give somebody like, a dose of antibiotics for 2 weeks or 7 days before. It doesn't work as well because it's that exposure to the antibiotics at the time of delivery, and really the loading dose, you give a loading dose, five, usually it's penicillin if they're not allergic or anaphylactic, and then you dose every 4 hours. So 5 million and 2.5 million every 4 hours until delivery. And really 2 doses of that is considered adequate prophylaxis, right? Or 4 hours after the first dose. Okay. So if you have somebody that's like a multip and she's GBS positive and she's coming in hot and she's trying to deliver a baby, you still try to put an antibiotic in, if you can. Obviously, whatever's emergent and safe, you do to start. But even just starting an antibiotic and getting a little bit of that in is quite worth it, to decrease the chances of that baby getting early onset GBS disease. What are the indications for IAP? So if they have a positive GBS culture at 36 to 37 weeks, and these cultures are only good for 5 weeks. So if you have a prima gravida that's going to go over 41 plus weeks, you actually have to repeat the swab. But if they're positive, they're positive. You only repeat the negative ones. Okay. If they're positive GBS, they're considered positive even 5 weeks after. Okay. You might get that question from your patients. Um, we talked about GBS bacteriuria. Remember a couple of days ago, where I was talking about, I don't know, when we were talking about getting that urine culture. We always get urine cultures where I work, because pregnant women are at risk for asymptomatic bacteriuria. And that's why we get that culture, kind of to see where they're at. At that time, it can show GBS, right? And if they're growing GBS in their urine, um, then they're considered positive. You don't even have to do the screen at 36 weeks. They're positive. Okay. Um, if they've had a previous baby with invasive early onset GBS disease, you're treating them with IAP. Not if they were just positive with GBS positive and nothing happened, that's fine. They have more likelihood to be positive in a subsequent pregnancy. But if they actually had a child with invasive early onset GBS disease, they're treatable. Okay, you don't actually need to screen them. They're considered high risk. Um, we talked about the first line treatment. Usually is penicillin, 5 million units, loading dose, and 2.5 million units every 4 hours until delivery. Alternative, if you have a non-severe allergy to penicillin, is cefazolin. That's an 8-gram dosage, or 2 grams loading dose with 8 grams, 1 gram every 8 hours. And then for severe, an alternative for anaphylaxis is clindamycin, if the bug is susceptible to clindamycin. Otherwise, you're getting the big guns, right? Vancomycin. Okay. So let's do a little bit of a case study. 32-year-old at 30 weeks presents with blood pressure, 160 over 100, proteinuria, headache. What is a diagnosis? Yeah, preeclampsia. And what are you gonna do now? What's your plan? She comes, you're the doc, you're on triage on your OB rotation, um, or just working in the OB triage, and this happens. Now what? You can use your mic, remember? Yeah.
I would give her max sulfate,
Yeah. And what else?
monitor blood pressure regularly to see how it's developing,
Mm-hmm.
try to control that. I mean, we could use labetalol or hydralazine
Mm-hmm.
to control it, or methyl dopa, whatever works, or is in the hospital protocol, and try to see how is the situation evolving. Like, do we have can we keep the baby in? Can we not? Like, is it like a unstable situation where we would eventually have to deliver? Um,
Mm-hmm.
with other pathologies evolving, and then 30 weeks also maybe then induce lung maturity eventually if we decide that.
Yeah. So the first thing, yeah, she's quite preterm. So we need to, so if they're coming in, they just got proteinuria and headache, 160 over 100. What I would probably do is I would get a urine sample, send it out for UPCR, and I would get some labs, right? I would make sure I could see what her liver function studies were doing, what's her CBC doing, in particular her platelets. Part of the platelets thing is that preeclampsia can end up to something called HELP syndrome, hemolysis, elevated liver enzymes, low platelets, HELLP. When that happens, you have a pretty serious situation. It can precipitate disseminated intravascular DIC, basically, which is otherwise known as coagulation, otherwise known as death is coming. So you really help is kind of like a trajectory for that. So that's preeclampsia can lead to that. Okay. So that's why you're looking at those platelets quite. So for her, she's 30 weeks. That's pretty severe. Proteinuria, sometimes those dips on the protein aren't super reliable. So with this, I'd get more evidence. I'd probably get her on the monitor, the fetal monitor to start with, to see what that baby is doing. You're going to get a tracing now. If they're less than 32 weeks, when we look at tracings, a few tracings tomorrow, they're not going to have the same diagnostic criteria that's normal. So usually it's 15 accelerations by 15, up by 15 by 15 seconds will give you positive X cells, which makes you feel like that baby is normal for 32 weeks unless it's 10 by 10. This will make sense tomorrow. Lots of questions.
I know that typically preeclampsia is like anything beyond 20 weeks with proteinuria and like, it being so you just mentioned that at 30 weeks it's pretty severe. Why does the weeks indicate severity in this
Yeah,
case?
it's not the weeks. I'm just looking at her blood pressure. The reason why I'm thinking it's severe is like it's presenting at 30 weeks, right? So usually preeclampsia will present later on gestationally, and you're higher risk in the third trimester, but it does sometimes present here. And if you're here at 30 weeks, we're really gonna try to do is to get her that a little bit further along in the pregnancy if it's controllable. So, you're probably going to be then getting an ultrasound, then seeing if she's treatable, if she's actually diagnostic for preeclampsia. Right now, you have a strong suspicion, right? But we need more quantitative data. And then once she's diagnostic, then you're like, this is an urban high risk place. And so that's what that, so then you're going to go on. And then if she continues to have that high blood pressure, let's say you started on labetalol, it's not controlled, her, she's getting more and more sick, it might precipitate delivery at this point. So yeah, there was a question over here. There is, yeah. Yeah. I can see you thinking about your rural Ontario place, right? In this case, if you're up in wherever you are in rural Ontario, In this case, you would be consulting with your obstetrician in the city or wherever your closest level 2 or level 3 is, and whatever system Ontario has. We have a different system in Alberta, but where we use a centralized line and then we patch to where we can talk to the people. But you would be consulting on that 100%. But what you would do first is you get your diagnostic stuff first. So you would be getting the labs, getting the UPCR going. You wouldn't wait for the UPCR, but like let's say you have like a sky high ALT or AST. She's pretty diagnostic. You're calling up because what are they going to say to you? The OB's going to say, well, what's her liver function studies? What so you're better off getting that. What's a baby like? Oh, you already went to you already got her an ultrasound in your hospital. Great, baby's fine, whatever. Yeah. So that's a good question because it's going to depend. Now, if you're already in your level 3, your friendly OB might already know this, kind of thing. Yeah.
So at what point would you start lung maturity slash also inducing the woman? Because I mean, obviously, if she remains unstable, I mean, the delivery of the placenta is the only choice. But where do you make that call and say like, okay, now we have to induce early? Because I mean, I guess vaginal delivery is still the method of
Yeah.
choice.
Yeah, I think so. In some cases, it's going to be very clinically dependent. So if she's continuing to have a increased um, blood pressure, it's not resolving with labetalol and magnesium sulfate, and or she has a seizure, or just or she's not able to um, kind of we're not able to maintain the magnesium sulfate, like she has toxicity with it, and you have to turn it off. Let's say that kind of thing. So it's all going to be very clinically dependent on when you deliver and what route. Now, prima gravida at I didn't say she's prima gravida, but at prima gravida at 30 weeks, her cervix is going to be nowhere. You're starting from scratch. So it's all going to be dependent on how she reacts to the treatment. Yeah. Any other questions? Okay, good questions. Okay. Okay. Here's another one. 28-year-old at 36 weeks has persistent itching, elevated bile acids. What's the next step? What do you think this is? ICP, right? So what are you gonna do with this? You're gonna get her on some, you're gonna talk to her about an early delivery, right? She's 36 weeks right now. You're gonna get her on UDCA, and you're going to talk to her about monitoring fetal movements because of the risk for stillbirth. You're going to make sure she knows that if she feels anything different related to fetal movement, that's our only way to know when they're walking around outside of being in our clinic, that baby is fine, and then have a plan for early delivery and follow up, right? Okay, so going back to our definitions of preterm, postdates, and postterm, again, you're going to see different places have little slightly different numbers here, but usually preterm is before 37 weeks. So 36 and 6 is preterm, okay? Postdates is any pregnancy that goes beyond 40 weeks. We know prima gravidas will statistically go about 4 or 5 days over their due date. That's normal. Um, Normal to have a post-dates pregnancy. Remember when we talked about dating, only 5% of babies are born on their due date. Post-term is then any pregnancy extending beyond 42 weeks. Kind of how often it happens. Preterm, 10% of the time. Post-dates, 50% of the time. So that's a lot, right? Half of the time. And then post-term is at about 5 to 10% of the pregnancy. Okay. Risk factors for preterm birth, so lots of them. If again, like anytime you get a question on any exam that says, what is a risk factor for something in pregnancy, is if it happened before, it's a risk factor. That's always one of the right answers. And it's the case for preterm birth as well. So if you've had a previous preterm birth, you're at risk for this. Multiples, twins, triplets, you have anything that like overexpands the uterus, right? So polyhydramnios, multiples, things like that. Polyhydramnios, of course, meaning if you have a large amount of amniotic fluid. Short cervical length, obviously, we talked about that yesterday. Infections, bacterial vaginosis, we also talked about that, but also UTIs, smoking, and any other comorbidities. So hypertension, diabetes, all at risk for preterm birth, and low socioeconomic status. Multiple risk factors involved with that, right? um, Risk factors for post-term prima gravida, right? Previous post-term pregnancy, right? Some genetic factors. Actually, somebody did a study about whether or not the male sex fetuses were more likely to go over term. I think it was probably some angry woman with her husband saying, "You're always late." But yeah, but anyway, male fetal sex, and then placental insufficiency. When we had those babies that were at risk for IUGR also can go post term. Um, so diagnosis, the first step is getting an accurate dating, right? So we know the best way to do that is that first trimester ultrasound between like, you know, 7 and 13 weeks, but you can get it up to 23 weeks and count that. Cervical assessment for preterm labor or preterm birth, and then fetal well-being. So your biophysical profiles. NST is just a fancy way, so a 20-minute on your electronic fetal monitor tracing. We're going to look at a couple of those tomorrow, and then your Doppler studies can also give you some more information. For preterm birth, we already talked about the corticosteroids for fetal lung maturity, really doing that between 24 and 34 weeks. Dexamethasone, betamethasone, tocolytics. If somebody's in preterm labor, we don't typically want to stop them because often it's something related to infection or something like that. When we stop it is when you have a prima gravida and she's not that far along, maybe 2 or 3 centimeters or earlier than that, and you need to get them into a higher level center where they can take care of a baby of the gestational age that she's presenting at. So that's why you would give that tocolytic. Magnesium sulfate we're using here in preterm for neuroprotection of the fetus. Actually, it's less than 33 weeks now, 32 and 6. So they kind of keep upping when you can use that. If they have premature pre-labor rupture of membranes, so that just means if you're having your rupture of membranes and you're not contracting, in a preterm person, it's PPROM. And you give antibiotics, and then you work with your NICU team or your neonatal intensive care unit team to talk about how to prepare for a child that may be coming out preterm with a lot of different way that baby is going to kind of transition into extrauterine life. For post-dates pregnancy and post-term, so around at 41 weeks, our SOGC says if a person wants an induction labor at 41 weeks, you offer it to them. But what we do now is that between that 41st and 42nd week, we can offer bi-weekly testing. So in the States, usually it's an AFI, amniotic fluid index, and an NST. In some places of Canada, or it can be a biophysical profile, which is looking at lots of different measures of the baby, breathing attempts, moving, tone, 5 different areas, and your NST, right, your electronic fetal monitoring. So anyway, that's what you do twice weekly, and then have a plan for induction after that. We don't tend to go really that past beyond 41 and 3, 41 and 4. Sometimes you have people that's like, I don't want to do this. So you start doing things like you start really talking about cervical sweeps at 38 weeks. We talked about that earlier. It's a super easy low intervention thing with a low number needed to treat. It's 8, which is phenomenal. So if you start doing cervical sweeps at 38 weeks weekly, you're going to have just a shorter a better likelihood that pregnancy is not going to go post term. So that's a really easy thing to talk about with your patients. We induce that labor anytime between that 41st and 42nd week, but usually around 41 and 3, we have a plan. So they do their biophysical profile at 41. And then if everything's fine, then we can wait a couple of days, and you usually have an induction plan. If you have a really stronghold person that doesn't want to have an induction, you can have another BPP and NST at 41 and 3, make a plan. But after 42 weeks, you really, and we're going to talk about the difference between intermittent auscultation and EFM tomorrow. We widely use intermittent auscultation in Canada. You will not see it used that much at all in the United States, which is too bad because it's really the way to know that the baby's heart is okay without having the electronic fetal monitors, which is just a kind of a screening tool, and it's not specific, right? So yeah, we'll look at that tomorrow, but if you have a postdates or post-term and you have a fetus that is has a biophysical profile without a score, like a score that doesn't have any attempts at breathing or tone, then that's a pretty big indication that that baby needs to come out. Okay, so now let's see if we're doing our post-assessment takeaways. What are the key risk factors for hypertensive disorders of pregnancy? Anybody want to shout them out?
Maternal age, one.
Yep, young in age, and older maternal age in pregnancy. Yep. Previous one. Yep, exactly. Yeah, everything is if they've had a previous, hypertensive pregnancy before, or they're chronically hypertensive. Yeah, they're at risk. Anybody else? Yeah, I mean, yeah, probably stress and things like that contribute to high blood pressure, probably more on the chronic side. But if you have chronic or gestational hypertension, you're at risk for preeclampsia. So, yep, definitely. How do we diagnose and manage gestational diabetes? Anybody remember?
The sugar tests.
Yeah, exactly. So you're doing the glucose challenge test, and then you're doing the glucose tolerance test. If they fail their first test. And yeah, you're getting that at 28 weeks because that's the highest time of insulin resistance in a pregnancy. And then we manage it by diet and exercise, right? That first step. And if we don't get sugars that are in that range of between 5 to 7, 5 to 8, then we actually have to work on getting them on insulin. Okay, what is the management approach for ICP and IUGR? Fetal monitoring, yep. We want to make sure that that fetus is okay for IUGR. So you're going to do your ultrasounds, Doppler studies, monitor the growth, and then, and serial ultrasounds for that. So that's going to tell us, is this baby growing? Do we need to plan for induction earlier on? ICP, remembering that we are going to get the bile acid level, right? And we're going to treat that with UDCA and make a plan for early delivery. We're going to get her to count her fetus's movements because she's at risk for stillbirth, right? Okay, how does PUPPs differ from ICP? That's right. That's right. Yeah. So pups typically has got no consequence for the fetus, but the mom has got is itchy. They're both itchy, but the other difference too is that pups has a rash associated with the itchiness, whereas ICP you don't typically see that. Also, the presenting areas are a little bit different. With pups, you usually have these, red bumps, on your abdomen, and with ICP, it's usually in the palms and soles of the feet with no rash. Having said that, you can get a rash because you're itching a lot with ICP. Okay, takeaways. Late pregnancy complications require early recognition and management. Your diagnostic criteria is based on clinical findings, blood tests, and ultrasound. And treatment varies by severity and gestational age. Okay, any questions about pathologies of late pregnancy? Okay, that's it. Well, I hope you have a very nice field trip today. I'm sure it's going to rain on you. I've noticed it rains here every day, but I like it.